slides. Thanks all.
Splendid, splendid. So let me take you back to 2600 BC. We've all admired these beautiful pyramids. They're precisely aligned with the constellation of the Orion. The outer mantle is composed of 144,000 stones. They're flat to the accuracy of 1/100th of an inch, and the thickness is about 100 inches. What led the Egyptians to be able to be so successful? Well, it all depended on the cubit. Basically, the cubit was equal to the length of the forearm from the bent elbow to the tip of the extended middle finger, plus the width of the palm of the hand of the pharaoh ruling at that time. They had a system in place. The master of measure was in granite. And then there were standards which were copied to the workers, the granite copies. The calibration frequency was every full moon. And the cubit, the set squares, and the plumb bobs was set up precisely at right angles. Because so much was dependent on the cubit, there was a performance measure thrown in. If a worker did not bring the cubit back, there was the death penalty. Turning to 1792 BC to Mesopotamia. And this is the code of Hammurabi. If a physician were to operate on a man, sorry, just one sec. For a severe wound and save the man's life, or if he open an abscess in a man and save that man's eye, he shall receive 10 shekels of silver as his fee. But if a physician were to operate on a man for a severe wound and cause that man's death, or open an abscess in a man and destroy the man's eye, they shall cut off his fingers. That was the performance measure they had. Performance is the most important part of our work areas, isn't it? And has been for millennia. Hence, there is a need for measurement of performance. And this measurement of performance is outcomes. The essentials for successful healthcare outcome measurement are that they need to be meaningful. We'd all agree with that. There should be very clear extraction methods. There should be no ambiguity at all. The definitions should be crystal clear. There should be a team that is properly trained in collection and analysis of data. And of course, it's extremely important to have repeatability. Now, some of the selection criteria, and these are questions that everyone who's interested in measuring outcomes needs to ask. What is the name of the quality measure? It's important to use internationally recognized terminology. What is the source of the measure? And it's important again that it's very transparent and where the source came from with proper references. What is the type of measure? Is it a process, outcome? Is it structural? Is it a balancing measure? Is it the best measure to serve the purpose of the project, or are we making do with the easiest measure available? So the need to think about what could be a better measure. What is the purpose of the measure? Sometimes it's accreditation, sometimes it's reimbursement, or is it something else? What is the unit of measure? Is it days, number of patients, incidents, 1 per 1,000 admissions, or what? How is the measure calculated? So it's very important to have the numerator, the denominator. Can factors influence the calculation? How is the data collected? Like manually or electronically? How often? How is it compiled? What is the source of the data? Is it patient record survey or something else? Who will collect the data? It obviously has to be the right person with the right training, the right orientation, the right motivation. How will the data be reported and analyzed? We need to decide on a report format. How will the data be analyzed? And what do changes in the measured values mean? We need to be able to interpret what is measured. Some of the healthcare outcome measures, they could be clinical outcomes, they could be patient safety outcomes, they could be service excellence outcomes, they could be patient-reported outcomes. Just spending a minute on who we are. Apollo Hospitals Group is India's largest integrated healthcare enterprise with a presence in primary, secondary, tertiary, quaternary care. We have more than 10,000 beds across 73 hospitals. We have a birthing center program called Apollo Cradle. Several of these. We have Apollo clinics, our primary care service. We have daycare centers called Spectra. We provide care at home. We have a network of dental clinics. We have a network of diagnostic services. We have more than 4,000 pharmacies, the largest in India. We have sugar clinics where we manage patients with diabetes. MedVarsity is our internet-based learning platform. Apollo Med Skills trains young men and women so that they can have a career in healthcare as technicians. Apollo Life is our wellness platform. Apollo Telehealth Services oversees telemedicine, and we have touched as many as 15 million lives. We also now have a new offering called Apollo 24/7. We have a global projects consultancy division that has been involved in projects in more than 20 countries. And the Apollo Hospital Education and Research Foundation oversees all education and research activities. And we have 2 medical schools and about 900 postgraduate trainees in 45 specialties and super specialties, and 11 schools and colleges of nursing and so on. Just a point about our credentials. 4 postage stamps have been issued in our honor. One when we turned 25, when we completed 15 years of liver transplantation in India, and we completed 20 million preventive health checks and 150,000 open heart surgeries. For us, outcomes have been very important, and our first foray into moving down that journey started with accreditation. So our hospital in Delhi was the first in India and the 6th in Asia to be accredited by Joint Commission. 8 of our hospitals are Joint Commission accredited, and we have 34 NABH accredited hospitals. NABH is the Indian standards for accreditation. But then very quickly after accreditation, we moved beyond accreditation to outcomes. We developed Apollo Clinical Excellence 1, which is ACE. This is a clinical balance scorecard. We are all very familiar with scorecards, but this is a clinical scorecard. We looked at 25 parameters. We benchmarked them against the world's best published outcomes. We have this all digitally available on the Apollo Lighthouse platform. And of course, we have a team that does audits. Each of the parameters is measured as a percentage, and the maximum score available for 25 parameters adds up to 100. And we get cumulative scores for the entire hospital every month, which I'm just going to tell you what we do with. Now, it's extremely important to get benchmarking right. And this can sometimes seem very complicated. Benchmarking is a systematic data-driven process of continuous improvement that involves internally or externally comparing performance to identify, achieve, and sustain best practice. When we first started this journey, honestly, it was quite complicated because there were just so many different measures and there were so many different benchmarks. So we then asked ourselves this question: how do we decide what we want to use as a benchmark? And the answer came from our chairman, and he said, well, it has to be the best published outcomes. So when there were multiple parameters that we were looking at with, say, several benchmarks for each, it was relatively easy for us. We had to go for the highest, the toughest, the best. So we looked at some of the most famous hospitals in the world. We looked at some of their benchmarks in terms of outcomes. We looked at all the published data. So it wasn't something that we believed was hearsay. It had to be published in a peer-reviewed journal. And we then zeroed in on the 25 parameters and the 25 benchmarks, which came from across the globe, published in high-impact journals. What we started looking at was developing the definitions, the numerators, the denominators, the exclusion criteria, the inclusion criteria, data collection methods were clarified, the frequency of collection, implementation, and giving tips on how we're going to implement and follow up. We need to develop a toolkit in terms of training, and we also had to develop audit tools. To give you an example of some of the benchmarks, so average length of stay post-angioplasty. So total number of inpatient days post-angioplasty, total number of angioplasties performed, inclusion, all patients undergoing angioplasties, exclusions, if anyone left against medical advice. The benchmark is 2.5 days. It's from Cleveland, and Cleveland contributed to some of the cardiac parameters that we benchmark against. And so if is equal to the Cleveland benchmark, you get a score of 4 and 4. But if it's longer, then you go down from 4 to 3 to 1 to 0. Acute myocardial infarction mortality rate. This is based on the US database. So we had a numerator statement, a denominator, inclusion, exclusion. And again, if it's where the US benchmark is, you get a score of 4 and 4. But you notice here that from 11.1 to 12.6, you go down from 4 to 0. For example, for coronary artery bypass grafting, where the inpatient survival figures, the highest in the world, are at Cleveland, which is 99.4. So if our hospital has outcomes comparable to that, they get a score of 4. But if they lose more than 2%, so if the survival figures in any hospital is 97.9%, they get a score of 0. Now you can imagine that 98% survival after a bypass is very good, but in our system you get a score of 0. A 1-year survival rate for kidney transplants, this is benchmark against Mayo, a 95.7%. So if it's comparable, it's 4 and 4. And if the survival figures go down, it goes down from 4 to 0. So we've had the opportunity of revising our parameters, making them more and more stringent. And this has also been published as a case study at Ivy Business School, which is one of the top business schools in Canada. To give you a sense of what the report looks like, this is a report, and you can see here 12th, so that's December 21, January 22, February 22. This is from one hospital, and like this, we have 25 parameters. This is from one particular hospital. And this is the data that we get from across the group. So we want each of our hospitals to be in the green zone. Green means a score of 75 on 100. And it's not easy to consistently be in the green zone because these are the world's best published outcomes. But so if you go 1 point less, you become orange. So it's 74. And if, of course, you go less than 50, it goes into red. That is the cumulative score. But then we also have green, yellow or orange and red for each of the parameters. And this is pretty tough. And we monitor this month on month. And this becomes a part of the review by the audit committee of the board. It's reviewed by the board. Give you a sense for the last 6 years, 82 baseline. And you see that we've consistently been above 80. But yes, we're very happy when we go down to 88. And then comes COVID. And, it comes down to 84, and then 21, we started to come back to 88. But overall, and this is for the entire group, for all the hospitals within the system. But it's extremely important to make sure that we are not missing anything. So you have to have a system, and we have a system of a clear audit, 360-degree audit. And like I mentioned, that this data goes to the board. And if any hospital is in the red, they have to give an action taken report on saying why they were in the red and how they will prevent going back into the red. And you'll be very intrigued to know that we've actually linked the CEO's appraisal to ACE. So it's not just about P&L, but it's about clinical outcomes, because conventionally clinical outcomes have always been about clinicians and nurses. But we've got the CFO, the head of operations, and the CEO's appraisal also linked to ACE. And I think that's pretty novel, and it shows the commitment towards measurement of outcomes and right across the organization. We then went on beyond ACE. We developed the Apollo Quality Program. Here we look at the international patient safety goal compliance, medication errors, standardization of diagnosis procedure codes, clinical handovers between nurses and nurses, doctors and doctors, and nurses and doctors, surgical safety. And we then develop the Apollo standards for clinical care. So they have the benchmarks. We have ACE 1, we have ACE 2, we have compliance with critical policies, plans, procedures, incident reporting system, mortality reviews, and the Apollo Quality Program. And we want every hospital to be in the green zone and a perfect hexagon, and we track data across the system, as you can see here. What have the benefits been? And I'm going to give you some examples. If you look at ALOS post knee replacement, down from 4.27 to 3.79 days. If we look at ventilator-associated pneumonia, you see here 10 to 0.95, and this is data for one hospital. If we look at the group level, considerable improvement over the years. We look at catheter-related UTI, again from 5.2 to 0.73. This is data from one hospital. If we look at group level, down from 0.77 to 0.64. Medication errors, specific intervention goes down from 2.19 to 1.35. So significant improvement. Needle stick injuries, a downward trend as we would want. If we look at patient falls, specific interventions in a particular hospital, patient falls come down by 23%. Increased compliance with 61% in terms of assessment and the time taken for completion of assessment. But I want to change track as I end. I don't know how many of you are fans of Prince, but Prince was a very popular pop singer, and in the early 90s, he made an announcement and he said that, from now on, he will not be known as Prince. He didn't need a name and he would be known by this symbol. So the media really didn't know how to handle this. And they said, how can Prince not have a name? How can he be represented by a symbol? So some of the media folks came up with the terminology called TAFCAP, the artist formerly known as Prince. The way medicine is evolving, I think we are going to have a new term now. We are no longer going to have a term patient, but we are going to have a term TIFCAP, the individual formerly known as patient, now a partner. And if we look at this relationship as a partnership, I think together we can scale new heights. And we always have to remember that we must hold a picture of a successful outcome in mind, as Thoreau mentioned years ago. Thank you very much. And that really brings me to the end of this presentation. Delighted to be a part of this webinar. Thank you.
Thank you so much, Professor. Wonderful, great presentation. So as we discussed at the beginning, one of the questions is, what is the role of outcomes in quality improvement process? And now we realize that this is a very important component of improvement processes, because basically it's the treatment that we provide to the patient. That's the purpose of their visit of the hospital, not to have tea with the doctor, nice discussion with the nurse. So outcomes are critically important. That's the key, the highlight number one, the key idea. So the second highlight is that the outcome itself, unfortunately, will give you very few information about the effectiveness of your treatment. You need to compare outcomes. You need to benchmark yourself. And this is also a very important component of your improvement work. You need to compare yourself not only to the same level facilities that might be in the same area, in the same district, but also to the publicly available data globally, so that the best players of the market, the trendsetters, you can compare yourself to them and strategically move towards providing better and better, safer and safer care for your patients. And now we move to the next speaker. Next speaker is Dr. Neo Tapela, Chief Scientific Officer of ICHOM. So Dr. Tapela, over to you, please.
Thank you very much. It's a pleasure to be here, and I really enjoyed the presentation just given, and I think it's a wonderful segue to what I will cover. So as mentioned, I am Chief Scientific Officer at ICHOM, and I'm also speaking as someone who is a clinician and has been involved in policy work in my home country in Botswana, and also has been an implementation researcher, so really struggling through how do you implement and scale nationally and regionally what quality value-based care looks like. And how to represent that in numbers in ways that are clearly defined, as has been mentioned, and is reproducible. So let me share my slides and just let me know if you can see these. Can you see my slides?
Yes,
Okay.
we can see your slides.
Great. So this slide I'll start with, and I like sharing it because it represents, it's a graphic of measures or of outcomes, and it's a variety of outcomes. If we start on the left side of the slide, this is a representation of survival, 5-year survival among prostate cancer patients in 3 comparative scenarios. So the first is, the first bar is Germany, national average of hospitals taking care of prostate cancer patients. Second is Sweden. And third is Martini Clinic, which is a center of excellence for care. So when we look and compare these 3 care settings by 5-year survival, we find that the outcomes, the results are similar, meaning that 95% of patients treated for prostate cancer are alive at the end of 5 years post-treatment. The next question to ask is, are they alive and well? And that's where we shift to the right side of the slide. And here, these are 2 additional outcomes where we're looking at incontinence, urinary and stool incontinence, as well as erectile dysfunction. And here you see some variation in the performance of the three comparators. And you see that Martini Clinic outperforms the national performance in Germany and in Sweden. So I think with much lower incontinence and much lower erectile dysfunction. So I think for me, this slide reflects 2 things. One is that looking at survival only scratches the surface of outcomes, right? And there's really a need to be able to look a little bit deeper to understand if there's, and if we only focus on survival, we are misled and miss opportunities to identify best practices, what best practice looks like in different settings. The second is that survival is only the beginning, right? So and I can say this also from experience as a clinician, patients often, when confronted with the news of a serious diagnosis, their first question, yes, is, will I survive this? But the second, almost immediate question is, will I go back to normal life? And I think it's important for us as providers, for us as health system and healthcare deliverers, as policymakers, as taxpayers, to hold up health systems to actually be able to deliver an answer to that second question to patients. And, you know, the example that I provide here is of being continent in terms of urinary and stool functions and and having a healthy sex life, which is a basic and shared human need and should be reflected in our assessment of how we evaluate whether healthcare delivered is valuable. So really it's with this backdrop of the shortcomings in the assessment and appraisal of healthcare that ICHOM was established in 2012. It was founded by these 3 gentlemen, Professor Michael Porter at Harvard Business School, Stefan Larsen at the Boston Consulting Group, and Professor Martin Ingber at Karolinska Institute. And it's an international, independent, nonprofit organization. And our mission is to unlock the potential for value-based healthcare by defining standards for what to measure in a way that the outcomes reflect what patients are most interested in getting out of treatment. And we do this by defining the standards as well as scaling use and measurement in that patient-centered way. This here is just to show where ICHOM's work and core business sits within the value-based healthcare framework. We sit solidly in the second circle there, which is to measure outcomes on every patient. And that is patient-centered outcomes, which I'll expound on more. So what do our sets standardize, and what do our sets contain in terms of what to measure? Firstly, I'll say, and I think this echoes what has already been mentioned, that we focus on outcomes, right? So there's many things you can measure in healthcare. Those include structural components, processes, etc. But we solidly focus on outcomes. And these outcomes are a combination of what you say are conventionally or classically the clinical outcomes, including survival, and also disease control, progression measures such as hemoglobin A1C, in diabetes. But they also include outcomes that are reported by patients. So ways in which from the patient's mouth and patients unfiltered or unedited by interpretation of a carer or provider, that a patient relays how their health is and has been impacted by the disease or treatment of it. And these come in different flavors. They include quality of life, but also different domains such as symptom burden, how much pain or how much fatigue is somebody experiencing following COVID, for example. And also function, how somebody is functioning physically. Are they mobile independently? Function in terms of mental health and well-being, and also social interaction and ability to go back to work. So we really see the components of our sets and the outcomes that are included therein as a holistic picture of, from the patient's perspective, of how the disease has impacted their quantity of life as well as their quality of life. In addition to this, I'd say that we standardize, and I really like what was described as, the long list of the things that you need to consider when you're measuring outcomes. And there was a lot of emphasis of, you need to be clear on the definition, you need to be clear on the data sources, because if you don't, if you're trying to compare outcomes in one hospital to another, you'll realize that you're comparing apples and oranges. So it's really important to be able to standardize and specify what you're measuring. For us, that means patient-reported outcomes, really finding instruments or questionnaires that are structured and well validated in different patient populations, and that measure reliably based on psychometric performance. It also means being able to say and specify the data sources for particular components and the frequency of when to collect information from baseline or a diagnosis or index, as well as 6 months after or 12 months after, depending on the type of disease that you're looking at. The last thing I'll mention, and this is very relevant to benchmarking, is that you also want to make sure that the analysis that uses the data that you've collected with these sets actually gives you results that are credible and fair. And that's really where we have included case mix variables. You want to be sure that if I'm comparing hospital A to hospital B, so for example, want to find out if the care for stroke between these two hospitals, if one is better than the other. But if hospital A has, on average, the average age of patients in hospital A is 95 years, but the average age of patients in hospital B is 70 years of age. If my outcome measure that I'm comparing is 1 year survival, and I find that hospital A, the one with older patients, has lower survival, do I conclude from that analysis that actually hospital A is delivering worse stroke care? The answer, of course, is no. You need to make sure that you correct mathematically for the differences in age between those two patient populations. And so you need to correct for age as well as gender where it's relevant, as well as treatment factors and disease stage, so that you really make sure that you are comparing in a way that's fair and credible. And to that, I'd also add, in addition to what we traditionally, or what often is done in benchmarking, which is to correct for differences in clinical risk, there's a need to also correct for socioeconomic differences. So education, other ways in which to make sure the populations are comparable. This is just, I'll breeze through this one, is just an illustration of what one of our sets looks like. So this is for prostate cancer, and you can see that it includes survival and disease control domain, acute complications, as well as patient reported health status, and some of the example of validated patient-reported outcome instruments that we've included. We have the way that we define these standards is a methodology that's been honed over 10 years now, and it involves the compiling of a working group that is made up of 15 to 25 international experts who come from different backgrounds: clinicians, researchers, developers of these instruments, patient representatives, and patients. And they come together over the course of 9 to 12 months and have a series of meetings where there's discussion. The discussion is informed by their expertise as well as systematic literature review, but they also is transparent decision decision-making that uses modified Delphi. And at the end, and they sequentially make decisions regarding what outcome domains should be covered for this disease, what measures are available, and which ones are useful to include for this disease. So at the end of the day, you end up with a set that defines outcomes that are scientifically based, include patient inputs, and have a consensus that involves international multidisciplinary experts. I'd also mention that in addition to patients and patient representatives being part of the working groups, we also involve patients further on in this process. There's an open review phase where surveys are sent to patients in different countries and different geographic regions, where they additionally vet what the discussions have been. So this is an example of such, where you have questions about pain, functional limitations for this particular disease, and how, and for a patient is asked to rate in their experience as a patient of this condition, whether this domain of pain or functional limitations is important or not important to assess on a day-to-day basis. The output of that process are a flyer and reference guide summarizing what the outcomes and outcome measures are included in the sets and the definitions of them, as well as a peer-reviewed publication, which is a way of disseminating information about the set, but also is another layer of scientific review and vetting of the set itself. These are available for free on our website, and so please feel free to look at them if that's of interest. This is a summary of the sets that have been developed so far. We are at 40. As I speak, we've just completed 2 more this month, and we anticipate that we'll have 46 sets by the end of this year. These are sets that cover over 50% of burden of disease and cover clinical spheres of cardiovascular disease, musculoskeletal disease, oncology, and maternal and child health, as well as mental health. And they've been developed in collaboration with experts of over 1,000 experts around the world and implemented in over 85 countries. I think even with, ICHOM is 10 years old now, and it continues to grow. And as mentioned, we continue to develop sets, but there are some challenges that are important to note as we think about really scaling and measuring in a patient-centered way in different settings around the world, including in emerging markets. I think one big one is really being able to measure the whole picture of the sets, and that those challenges include the IT infrastructure and the how to. You might know what to measure, but how to in terms of change management and incorporating data collection in a way that doesn't disrupt clinical workflow. The second, which has already been alluded to, is actually being able to analyze and benchmark in a way that is fair and credible. So how do you do that and compare care in different countries, for example, or hospitals in different countries, if the way that race and ethnicity is measured differently, or if the deprivation scores are different from one country to another. So these are challenges for us to keep working and bringing emphasis and research and experience into. This is my second to last slide. It's just an overview of what ICHOM's work is and our approach to being able to drive value-based healthcare globally. So we define standard sets, as mentioned. We also drive measurement and adoption of these sets by disseminating lessons through conferences, newsletters, and publications. We actually have our next conference this year in November. It will be in Boston, so there's an opportunity for in-person as well as virtually joining. So please look it up on our website if this is of interest. We also continue to drive measurement by easing implementation. So our sets are now digitized, and we're now working on developing profiles for FHIR for the set, so for easier interoperability and integration with electronic medical records and mobile phone phones, etc. We will be launching a training and implementation support program later year as well, with a particular emphasis of how do you implement and measure this way in settings that have lower resources than, for example, academic teaching hospitals or high income private sector hospitals. And then lastly, we're really grateful for the networks that we've built with over 1,000 experts around the world, but continue to want to grow towards that end. We're also looking to really engage stakeholders that are relevant to policy change. And that includes policymakers, that includes civil society and patient advocacy groups who will help make hospitals and systems measure differently and link that measurement to reimbursement so that you really do have sustained and a change in practice. So that in summary, I hope I've been able to share with you that outcomes that matter to patients are more than survival or quantity of life. And when we reflect on clinical outcomes, it's health outcomes holistically. And that ICHOM serve as a tool for measuring these patient outcomes in a manner that's scientifically sound, incorporates patient inputs, and is based on a consensus that's really multidisciplinary and international. And I've just touched on a couple of considerations to make on implementing in your own healthcare organization setting, and resources that are available on our websites and elsewhere that might be the next step for you if this is where you are. And then just lastly, I'd look out for a paper that is coming out in the next month that speaks in more detail from what I've touched on, and a way to reach us. I really hope you can email or reach us on social media. So with that, thank you. And I really look forward to the questions and answers and discussion that will come from this.
Thank you so much, Dr. Tapela. That's wonderful presentation. And I just wanted to describe the key highlights, just the key messages that Dr. Tapela mentioned in her presentation. So number one is, of course, the importance of standardization, and that's what Dr. Sibal was also talking about. And when we do the benchmarking, we need to always remember that we should be comparing apples to apples and not apples to oranges. That's why methodology and the terminology become so important, and we need to be very careful about choosing specific indicators and comparing them. And the second very important message of this presentation is that basically outcome is more than just survival. There is one outcome measure that every hospital around the world, every facility is collecting and reporting. That's the mortality rate. But these days, we are talking about the quality life of the patients. And this gives flow to many more outcomes, many more indicators that become possible, especially if we're talking about chronic conditions which require compensation treatment. And here, we need really to learn and continue our improvement in order to make lives of our patients better and quality of their life specifically. Before we move to the next speaker, I wanted to pass the floor to Natalia to make one technical announcement. Natasha, the floor is yours.
Thank you. My technical announcement relates to a shared link that was used in today's webinar invitation. We have about 25 to 30 people that joined using one and the same link, and that is the link that names you as Maria Kuznetsova. And we are welcome, you're welcome to this webinar, whatever way you join, that there is just one, yes, like this. Exactly, thank you. There's just one specific thing about it, that because you're using one link, we do not have your emails, and we may not be able to send you the slides from today's presentation. And I realize that this is valuable to you. So what I can suggest is that, can you please let us know your email, either in chat or better in Q&A, or you can type your email. Just make sure to type it very correctly. Check the spelling when you are submitting the survey on exit. There's an open-end question, number 4 in that survey on exit. You can just please send me the slides too and your email, and we will be sure to do that. We want you to have the slides. We want you to join the webinars. This link was distributed in error and be avoided.
Thank you very much, Natasha. Thanks a lot. And now we move to the third speaker. That's Michael Giuliano, an executive director of ICHOM International. So Michael, over to you, please.
Thanks, Julia. Give me a few seconds to share my slides and I'll get started. As I'm doing that, thanks for everyone who's joined. Really appreciate your time, and great to follow such great speakers like Professor Sibal and Dr. Tapela. It's been great to learn from you, so thank you for sharing all of your background and experience. What I'd like to do today, and hopefully everyone can see my slides, is to round out the webinar by sharing perspectives from a global level, so high level trends in what we've been seeing at ACHS International in our clinical indicator program around measurement of clinical outcomes, structural and process measurements as well, in terms of the improvements and sometimes the deteriorations in healthcare as well. I'd like to ensure that we also make a link to how we use this performance data to continuously drive quality improvement in the services that we offer. And also importantly, share with you at the end of the presentation some warnings and pitfalls that we have collected over many years with working with organizations around the world and in Australia, so that you're aware of some things that can potentially misinform what data collection and reporting may tell you, to ensure that we are using data to particularly drive and improve patient outcomes and patient experience. So this is just a quick overview of what I'd like to discuss today. I'll first go through some reporting and analysis that we have collected year on year since 1990 and share with you some of those trends. Then particularly dive down into a case study of one hospital in terms of the indicators that they've collected over a period of around 10 years and share with you about how they used and analyzed that data. And then finally wrap up with some warning and pitfalls so that you can take that away, particularly around how you're using and understanding data at your own facilities. So just to start off with, I think it's always nice to start a presentation with some quotes. And these are standard quotes that I think everyone has seen many, many times when we discuss healthcare data and performance measurement. So from Deming, "In God we trust, all others must bring data," and Peter Drucker, "What gets measured gets managed." At ACHS International, we'd like to think a little bit differently about data, particularly nicely summarized by John Jones at the bottom of the screen here. So starting off with what Drucker said, what gets measured gets done. I think we can all agree that's foundational. But what gets measured and fed back, so fed back to staff, fed back to communities, fed back to patients, is done well. And then finally, the third component of that is what gets rewarded gets repeated. So if we're measuring something, it's being done well through feedback, we need to ensure that's sustainable for the long term. So rewarding those, whether or not it's financial incentives or just celebration and praise, to ensure that good practice gets repeated. So really the main takeaway here is that we need to think about using data not just to ensure that we get things done, but get it done in a repeated way. And another key message that you can see in the middle is just we need to be careful about the data that we choose, how we analyze it, and then obviously importantly, what decisions and actions we make based on that data. And I think that has been a common trend throughout what Dr. Sibal and Dr. Tapela have been talking about in their presentations as well. There's tons of data out there, sometimes a bit of data paralysis, being too much data to use. But we really have to be clear around what's the purpose and how we use that data to drive improvement. So what I'll be using for some real life examples throughout the presentation today is the CIP, or the Clinical Indicator Program. The Clinical Indicator Program is one of the many services at ACHS International, which has been running since 1990. Our Clinical Indicator Program at the moment consists of 21 indicator sets across various specialties that you can see on the screen. We're introducing a 22nd indicator set this year around geriatric care and aged care in particular. Within each of these indicator sets, we have over 330 specific clinical indicators. very much like Dr. Sibal mentioned in his work at Apollo. Each of these indicators are developed by the specialist medical colleges across Australia and New Zealand with input from patient representatives and patients as well. So very similar to what Dr. Tapela was mentioning in the ICHOM development process. This is to ensure that the indicators that we are creating, including inclusion criteria, exclusion criteria, measurement, clinical indicator manuals, numerator and denominators, are hitting on all of those key aspects of relevance, that the indicators are actually making impact in terms of movement and improvement in patient care, and are important to patients as well, and important to multidisciplinary aspects of care delivery. So everything from medical to nursing to allied health. So all of these indicator sets are made available, and they are currently being used across the Middle East, Asia Pacific, and Australia. We've had about 800 facilities participate each year in multiple aspects of these clinical indicator sets. And the real benefit of it is that we can do international benchmarking, trending, comparison, pure comparison based on some stratification variables throughout the world as well. And this really provides a flag or insight to hospitals about how they can make improvement in quality and safety. Overall, ACHS International is a quality and safety improvement partner. So in addition to our clinical indicator program and focus on performance data, we also offer international accreditation, consulting and education, not only around accreditation, but also around how you use the performance data to then interpret it and drive and create improvement activities at your own organization. So we really try to focus on how do we take the information that we gather and make it into an implementable, long-term sustainable improvement for our patients and for our staff as well. So just to give you a little bit of insight about what our indicator reports look like. So as I mentioned, we have 3 different types of report for every indicator in our program. It's called General Comparison Report, which compares all organizations across the world that submitted data. We also have a peer comparison report, which then sort of filters out organizations that are not like you. So we compare metro to metro, regional to regional, highly acute facilities to other highly acute facilities, et cetera. And finally, a trend report, so activity over time. What I'm showing on screen today is just a really quick snapshot of one of our general comparison reports and how we showcase our data in an easy to use way to start to drive improvements in outcome and experience. You can see here each of the indicators is named, so unplanned ICU admission equal to or less than 24 hours after procedure. Each of these indicators has either an L or an H, meaning that we want it to be as low as possible, or if it's an H, be as high as possible. All of this information is collected in an online system, making it very easy to look at our clinical indicator manuals, submit the data, and then receive reporting afterwards. We work with lots of different organizations in the background at AC in Australia to do statistical analysis, which I won't get into here today. But what we do is, over a global perspective, is look at what your expected number of events would be based on a global aggregate, calculate an aggregate rate for all organizations that did participate, and then determine based on confidence intervals whether or not the way that your organization is performing is either statistically better or statistically worse than a global aggregate average. And that's how we flag here in our program, whether or not with a red flag or gold star, whether or not you're statistically better with a gold star or statistically worse than the aggregate, a red flag. And that triggers to us additional support that we offer organizations in terms of then interpreting and digging down deeper into what that indicator is saying, the reasons why that indicator is showcasing that outlier, and then how to make improvement plans from there. This is just, again, a quick example of how we use that confidence interval to really showcase flags or stars in terms of overall performance. As I mentioned, this is a third type of trend report that we offer. This is trending performance over a period of time. So I believe this one is actually referring to ICU readmission within the 24 hours that I mentioned on the previous slides. And as you can see, for this hospital has been participating with us since 2010. And over a period of time, we can see that the aggregate rate has gone down. So overall, globally, it's gone down, which we can see in the gray line. But for this particular hospital, we can see their individual rates, the blue lines. While it does go in peaks and troughs over a period of time, we can see the fitted line or regression line in black going consistently downwards. At a global level, we can also see the 80th percentile in red and the 20th percentile in green also narrowing. And that indicates to us over a period of time that there's decreased global variation in terms of the way that data is spread. So that's a good sign that this is decreasing, but also there's still room for improvement. Not necessarily for this organization as they've gone down to zero and sort of maintaining that in the past few years, but from a global perspective that we can see with the overall aggregate rate. This can also be a great tool for quality teams to showcase whether or not there is a linkage between what they're doing in terms of improvement activities and what the data is telling them about how successful those improvements are. And sometimes those activities are multi-year, and sometimes those activities don't work, as we can see in this data here. Sometimes it goes up in the wrong direction, but this is a useful tool to re-guide some of those questions to ask, and then rework some of those improvement activities to steer organizations back in the right direction. So I'd just like to spend some time now talking about global trends. Now, with all of the information that ACHSI collects globally each year, we publish a freely offered report called the Australasian Clinical Indicator Report, which I'll make available to the IFC team so all of you can review that. It's a very detailed report that goes through indicator by indicator with commentary from our Australian and New Zealand specialist colleges around what they are seeing from a multidisciplinary perspective about the trending performance globally in those particular indicators and indicator sets. So just a quick summary of the report that we have most recently offered and give you a sense of the scale. In 2020, as we're just finalizing our 2021 report, we've had almost 28,000 submissions. Majority of those were from public healthcare organizations, about 42% from the private sector. And what we found is that from that data, there have been about significant improvements in around 118 of our clinical indicators, which meaning less than half there has been sort of stabilization or deterioration. So what we do in this report is provide a global overall trend around what are those top indicators that are showing most statistical improvement, and what are those that are showing most global statistical deterioration. And I'll go through some of those with you on the next few slides. Just an overview of that deterioration and improvement by our 21 indicator sets. We're really seeing that in terms of overall percentage-wise, the most global improvement in emergency medicine and pathology. But on the flip side of that, we can see some of the most percentage-wise deteriorations in those areas as well. But we can see in gynecology and GI and endoscopy sort of deteriorations not offset by improvements in their overall clinical indicators based on the information that we collect, of course. So this is really interesting sort of high-level overview around, especially in 2020 when everyone was hit by the worst beginning of COVID, how this is starting to flow through in data as well. So just to give an overview of a trending report, and this trend report that you can see on the right is not a trend report for an organization as I showed before, but this is a trend report globally based on all of the information that we collect from those 28,000 submissions in over 800 organizations. This trend report is for an indicator about relief of respiratory distress in the recovery period. Quick snapshot, this is not our whole clinical indicator manual, but we can see we define the numerator by number of patients undergoing a procedure who require tracheal intubation or insertion of a laryngeal mask to relieve respiratory distress in the recovery period. And that's over the number of patients receiving post-anesthesia care who are admitted to post-anesthesia recovery. Now we can see over a period of time that there is stabilization in the aggregate rate, but a sharp decrease in the trended amount globally, which is great. And we can also see variation is decreasing as well with the squeezing of those red and green lines. From our analysis of those organizations that did participate in this work, we can see a lot of the improvements have been linked to the difficult or adherence to the Difficult Airway Society guidelines, the use of CPAP machines, use of remifentanil, and also work in terms of public health activities before and after procedure around smoking and alcohol cessation. So clearly there's a lot more information here. But this is just one of the interesting improvements that we've seen rise to the surface in our latest report. Another improvement, which is really interesting to see, is medication errors, adverse event requiring intervention. So this indicator, which you can see over a period of time, measures the number of medication errors resulting in an adverse event during routine observation and monitoring, divided by the number of occupied bed days. And you can see sort of the aggregate rate sort of is a little bit chunky here over a period of time, but eventually, as we get from 2017, starts to see a sharp decrease in the global information that we've received. And that aggregate fitted regression line we can see in black is consistently downward as well, which is great. And again, that variation line is continuously to go downward to ensure that they're squeezing the amount of percentile variation that we're seeing. And again, in terms of discussion with our organizations about what is driving your improvements in this area, many of that is linked to implementation of electronic medication management systems that are improving not only the recording of information, but cultural change around the importance of reporting adverse events, linking that to trending, linking that to performance data, and then linking that to improvement activities to drive better outcomes, as we can see in this graph. Interesting though, there are some deteriorations that are of concern at the global level that are useful to be aware of. And again, I'd welcome you to read the report, which provides more information here. One of the deteriorations that we're seeing consistently over a period of time is the induction of labor. So the numerator here is selected primipara, so women who are giving birth for the first time who undergo induction of labor, over the number of selected primipara who give birth. As you can see by the graph, this indicator is supposed to be going lower based on the clinical advice that we receive from our development process. But obviously you can see here by the graph, it's very clear that it's increasing, particularly in all of the 80th percentiles aggregate rate, as well as 20th percentiles. And again, we have to understand like the improvements, what is driving that. So we're seeing in a maternal population that they're older, more obese in general, and lower planned future parity as well. This is driving higher induction of labor. As we can see, they're more aware, they're balancing risk mitigation versus leaving it to nature, just sort of having birth naturally. And we're also seeing a slight increase in larger babies as well, which is for clinical reasons showing induction of labor as well. So lots of different sort of factors at play here. One of the key takeaways that we always work with organizations on is that just don't always look at your data at face value. Really start to interrogate and ask questions of that data because it may show you different things happening in the background. Another deterioration, we're seeing mechanical restraint greater than 1 episode. Again, this is an issue, I believe, across the world and something that Australia is focusing on, not only for mechanical restraint, but chemical restraint as well in many care settings, particularly the residential aged care setting. This shows the number of consumers who have had more than 1 episode of mechanical restraint per visit. What we're finding, again, this is supposed to be going downwards, but it's consistently been going upwards globally in the information that we've collected. That tends to be a connection between seclusion and restraint that are linked. There's increase in restraint due to increase in aggression in particular cohorts, particularly mental health care. And there seems to be an emerging area of study and ethics around what is best for patient care and patient outcomes in terms of when to use or not use seclusion or restraints, but there doesn't seem to be an easy solution yet or a clear solution yet around how that can be applied in many healthcare settings. So that's probably what we are seeing driving this increase. Just to wrap up with a quick case study, I just want to make sure I'm staying on time. This is one organization that we've worked with. They've come to us and said, look, we're not happy with our ICU indicator, which shows adult non-admission due to inadequate resources. Basically mean adults not being admitted to the hospital's ICU because of lack of beds, lack of staff, whatever the case may be. We can see here over time that we want this indicator to be going downwards, but the fitted line in black is actually going upwards. And we can see there's some sort of intense volatility in the number of this non-admission in the blue line. But surprisingly, not surprisingly, but happily, we can see lately since sort of 2018 that there's been a decrease in a number of these non-admissions at this particular hospital globally. That is showcasing that something is happening that's showing improvement. This is the indicator report that they brought to their quality committee that I was showing you in the beginning, which was showing a red flag, so statistically not performing within the global aggregate. What they then did was to respond by developing an exit block project. What they found was this data flag to them that non-admissions were due to not getting patients out of ICU on time through discharge, through other issues that may have been through availability in other parts of the hospital or availability for resources outside of the hospital. They then started to collect data monthly and created a team to look specifically at this. And I believe, as Dr. Tapela said as well, this does take a lot of change management as well, particularly around the culture of how you use data and respond to it. And they also made some workforce changes as well around hiring more bed managers specifically for the ICU to be in charge of that sort of, sort of overall management, like you would in an airport, for example, air traffic control of where the patients are moving in, how they're moving out, when's that planned, and being more proactive about that planning as well. Just to wrap up with some pitfalls that I think are useful for everyone to be aware of. One of these, as we start to look at data and analyze it, as I mentioned before, that we shouldn't just take data at face value, is really to interrogate and ask questions of it to ensure that the decisions that we're making based on this data are actually what is happening in practice. One of these interesting phenomena is called Simpson's paradox. And this is basically when there is a trend that appears in several groups, but when you put those groups of data together, that trend disappears when you combine them. This was interesting in an article that I was reading recently, that a country, and obviously this is very topical, a country reported from its ministry that around 60% of people hospitalized in that country with severe COVID had received 2 doses of the Pfizer vaccine. They then reported suggesting the efficacy of the vaccine in preventing severe disease dropped from 90% to 64%. And obviously that is very concerning. But if you look at then disaggregating that whole group of data by age group, what you then can find here is that people under the age of 50 actually had 90+ effectiveness from the vaccine at preventing severe disease, and people over 50, 85+. So if you're just looking at face value, as I mentioned, this looks quite concerning, this drop from over 90 to 64. But being aware of the Simpson's paradox, once we break that into age groups, and again, if you break that down further, we actually see it's not as concerning, most likely as we had originally thought. So just something really interesting to think about. Some barriers to improvement that I believe have been touched upon in many different areas and discussions today are data collection difficulties, especially data collection that is still paper-based and manual. Standardized collection, we see this a lot in our indicator around core body temperature. Lots of different clinicians can sometimes have varying instruments that they use, calibrated differently. different ways of measuring core body temperature, different timings, etc., which can show variations. Sometimes in a very busy healthcare system, there's no capacity or capability to collect, analyze, and interrogate the data as we discussed. Sometimes there's analysis paralysis. There's thousands and thousands of indicators, some forced upon us by ministries that are required, and sometimes it can be very overwhelming. There's always this question about, really, does measuring ensure patient safety or have an impact on patient safety, which goes back to the John Jones quote that I mentioned in the beginning. It may, but we need to ensure that we back it up by reinforcement and reward. Most interesting is that sometimes there's an assumption of frontline staff or individual facilities that because I am measuring something, someone else at a higher level will be responsible for intervention or performance management or trending. And we found amongst multiple issues at Mid-Staffordshire in the NHS that this was one of the key issues, particularly around governance and accountability and responsibility of data about, well, I collected it, now someone should be telling me what to do with it. And there were huge gaps in that not happening, and then a huge impact on patient care, which leads to the real importance of leadership and staff engagement, an entire process that is very critical, not just in healthcare, but obviously performance management as well, and performance data. There's always this issue with collecting indicators around gaming indicators, that people will leave off data to make themselves look better. This doesn't actually, in our experience, at least with our clinical indicator program, doesn't happen as often as might be expected, which is great, but it's always important to look out for potential opportunities or potential cases where organizations do game indicators, meaning that they're only reporting what they're doing well in, leaving out what they're not doing well. Sort of using the close enough technique. For example, core body temperature should be 36 degrees Celsius or higher, but if it's 35.8, oh, that's close enough to 36, we won't report that. I think, as mentioned previously, some of these solutions to help with this is agreeing an organization-wide set of indicators so that everyone is on the same level playing field. Auditing those indicators, as we saw with the 360-degree feedback from Apollo from Professor Sibal, including those automatic data collection and short manual audits as well. And then finally, just a little psychology, I guess, about how humans think about data, is that we have inherent cognitive biases about the way humans think. And the assumptions that we make that we just need to be aware of and catch ourselves if we think we are doing this in terms of the analysis of data. One of that is information overload. So as I mentioned, especially with COVID, lots of things are happening. We're short on staff. We still have all of our reporting requirements that our brains naturally try to aggressively filter out all of the noise that is happening to look for a signal or a flag or a trend in the data. And sometimes that may not be accurate, but what we sort of go to by default. We also, when there's a lack of meaning, it can be very confusing to us. So if we're not seeing a trend or if we're not seeing things that make sense in the data, what we naturally do is try to fill that gap and construct a story which sort of reduces our anxiety, but that story may not be based on actual fact. It may be based in illusion or in what we want to see in the data. Sometimes we jump to conclusions, and this happens quite frequently, that when we see an initial data point or we see an initial trend, we act very quickly to say, I know exactly what's happening there, or I know what may be causing that, instead of looking at that data and asking questions of it, which may tell us a different story, or may back up our initial assumption. And then finally, we only remember useful bits of information. So complexity, that we lose some sight of the overall picture sometimes when we dive deeply into a indicator, etc. This is why at ACHS, we really recommend that you not look only at individual indicators, but you look and create an indicator journey around different structural process and outcome indicators of around how a patient flows from before they arrive at your facility, when they're in your facility, and when they exit, so that you can be flagged to useful bits of information across the spectrum. So thank you everyone for your time. Thank you again to IFC and all the other speakers, and really look forward to the question and answers. Thanks again.
Thank you very much, Michael. Very useful information, great presentation. Just a few highlights before we move to the section of questions and answers. And I wanted to say that we are getting lots of questions today, so it's going to be very interesting discussion further on. So now we understand, after we listened to our three experts, that definitely outcomes are worth measuring. Now we are do not question ourselves whether we should do it or not do it. Of course, we should do it. So number two is that we need to benchmark. So outcome by itself does not give you much information about how well you are performing. You need to compare yourself to your peers, to similar companies around you, and also to the global leaders. It's also useful for your growth potential. And also your benchmarks your outcomes, the indicators, clinical indicators, specifically outcomes, they of course should be analyzed. So you need to identify the root cause. If something is not going as good as you expected, or you compare yourself to your peers and to the global leaders, and you understand that probably you're not doing very well yet, or certain indicator dropped, then you need to do the analysis and implement corrective actions, because we are gathering statistics not for the sake of statistics, but to identify risks and potential areas for improvement. Also, we shouldn't jump into the conclusions, and Michael proved that with his presentation. We need to be very careful about making conclusions considering all the factors, and this is something that we keep repeating during the previous webinars devoted to data collection. It's very easy to be misled by wrong conclusions if we do not work with statistics properly. It can drive you up the wrong track very easily if we don't pay enough attention to it. And also do not game with numbers. Do not try to look better than you are, especially lying to yourself. If certain indicators do not look good enough, do not try to hide them. Try to find the reason why it's that, if that is like that, and then you can improve. So be honest with yourself. This is one of the key ideas of the presentation of our third speaker today. So now we move to the section of question and answers. And the first question, to our experts is actually the one that we received many times. So say there is a hospital that measures mortality rate, reports it maybe to the government, also measures some readmission rate from time to time, not maybe doing it properly. By the way, we did a poll in our knowledge sharing group on Facebook, and our hospitals replied that they do measure mortality rate and that many of them measure readmission rate. So say such hospital wants to measure more outcomes. What are the first steps? How to choose the outcomes to measure and where to start? Michael, Neo, Dr. Anupam, please, you're welcome. Who would like to be the first to give advice on starting the journey of measuring outcomes?
Well, if I might give it a go. See, the idea is you have to measure what's most relevant for you. And while there might be databases available, but you have to see why you're measuring it and what's going to have the greatest impact in your organization. And it also, I mean, some of the questions that keep coming up is that, how do you get a buy-in from clinicians? How do you get a buy-in from administrators? Because there's always a champion for everything in the world. Well, you have to rope in the clinicians, because believe you me, what they're really interested in is excellent outcomes, because that's what a doctor's supposed to do. Make sure their patients go home happy, well, and as Natalia said, not just looking at outcomes at discharge, but follow up, because that's really important for many, many conditions. It's not just about that episode, but it's about long-term care. So I think a conversation with the clinicians, is the first step in getting a buy-in. Of course, we were fortunate that we managed to convince the board that we have to link the appraisal of the CEO, CFO, and the medical head. I'm not sure how many organizations in the world can actually do that, but we did, and it mattered a lot, because now in every discussion that we have, while you discuss the financials and you discuss CapEx and you discuss equipment purchase and you talk about recruitment and so on and so forth, but you also talk about clinical outcomes. So I think and you are clearly the champion if you're asking this question, get a buy-in, have a dialogue with everyone, who's going to have an impact in this process, get all the stakeholders to start talking about it, and the process will get underway. It of course takes time. It's not going to happen immediately. It's a slow process, but then you have to be constantly at it. Thanks.
Thank you very much. I echo everything that's been mentioned, and emphasizing that the most important thing is buy-in, and buy-in comes from identifying what's relevant and useful to your organization or your hospital or your department. What I'd also add is that, and this is from having worked in academic teaching hospital in the US, working in rural hospital in Rwanda, and seen many different contexts, and recognizing that the challenges to implementation are different and harder in resource limited settings. I would also add that it's good to start with low-hanging fruit. So among the possible things you could measure that people in the stakeholders in your setting find important, pick the ones that are low-hanging, meaning that it's a smaller lift. They're already collected in some form, or it would be easy and wouldn't interrupt clinical workflow as much to collect them. The other thing I'd say, a question that often comes up in conversations of implementing our assets is, do we have to be digital, right? Paper-based is cumbersome, but you can do something, right? So I would say start somewhere with low-hanging fruit with what you have. And the most important thing is to start a culture and a practice of measuring and using the measurement and improving. Then with time, you'll be able, with that culture and people seeing the small impact that you've started with, then you can add more data points to measure and be more bold and start investing in digitized mechanisms of collecting data.
I would certainly support everything that you just added there, Dr. Tapela, because that's, as I mentioned in my presentation too, really the key success to making the investment in data work, particularly around even before you start asking people to collect information, is setting that culture and that feedback loop to ensure that people can really see the work that they are doing, the improvements that they're making, the additional work that they may feel that they are doing, collecting data is actually making an improvement. And that's circled back to them. So that engagement piece really comes full circle as well. The other thing that we work with organizations on is to ensure that those indicators that they select are responsive. So you don't want to obviously be doing lots of work and not see your indicator move in either direction, positive or negatively. And that gets to Dr. Tapela's point as well, is that as particularly in the beginning, you want to be showing and creating that positive culture that yes, by measuring, we are making improvements. But if you're using non-responsive indicators that are hard to budge in either direction, that can create some sort of discouragement and lack of motivation even before you get going.
Thanks a lot to all of our experts for all your answers, very useful tips for the beginning of the journey. Just one little clarification that we also received several times from our audience is lots of hospitals, they work with visiting doctors. So any tips from you how to get buy-in of the doctors who are not full-time staff but visiting? So how to bring them on board and how to persuade them to participate in this program of measuring outcomes. They sometimes perceive it as an obstacle rather than area for opportunity for improvement.
Well, I think it's a question about building a culture on constantly improving on patient safety, on quality improvement, and measuring outcomes with a view of ensuring that every patient gets the best care. So either you believe in that or you don't, whether you're full-time, part-time, honorary, visiting, it doesn't matter. It's a question of you are delivering care within that ecosystem, and that's what the ecosystem believes in. And if it does, then, and you're a part of it, then that's that. It's about having the dialogue, and it's about sitting down and actually talking about why it's important. And sometimes it requires multiple discussions.
Thanks a lot. That's a great point, Professor. So Dr. Neo, your microphone is on. You wanted to add something?
No, I forgot to turn it off. I'd say I don't have much more to add. I might maybe just agree with that. It's a dialogue and culture. And I think I'm not quite clear on who the visiting professionals are. They visiting sort of rotating between hospitals or coming from out of the country, et cetera. But what I would say is that if somebody chooses to participate as part of an ecosystem and part of the hospital, they also need to abide by and buy in to the organizational expectations of conduct and what they define as quality.
Thanks a lot. Another very practical question that we also very often receive from different facilities is actually measuring the mortality rate. So what would you recommend? So how to measure justified mortality rate or just average mortality rate, maybe some resources that you can recommend, because this is one of the most controversial points really, because it's one of the most misleading, potentially misleading really indicators if it's not measured properly. So what advice can you give on measuring mortality to our audience?
I might start on this. I mean, my answer is it depends. And firstly, it depends on what patient population you're looking at, right? For example, we know that in cancer, it's actually not so much mortality that's important, but you want to know what the survival is after I've been diagnosed with breast cancer. What are my chances of being alive 5 years from now, right? That's the first thing, is what population and what do you hope to use, what information do you want to get from that data? I think the other, and again, thinking about developing country settings or, lower resourced settings within countries, is that of data quality and availability. And I'm from Botswana. I've worked in a lot of different countries in sub-Saharan Africa, and we have big challenges in terms of understanding or having completeness of mortality data, just overall mortality, right? Not even thinking about cause of death, right? And then even bigger gaps when you think about the cause-specific type of mortality. So I think the second consideration is just a pragmatic one, where can you start? Where's the data that is low-hanging, that is available, that you could start with? And then again, keep improving and building upon that over time.
Thank you very much, Neo. Professor, your microphone is on. Does it mean you wanted to say something?
No, I echo what Neo's saying.
Okay. So next question is also a very common question that we get almost every webinar. So measuring outcomes is obviously part of the quality improvement work. So is there any connection between these efforts and financial returns? Is it recognized, like better outcomes? Would it be recognized by the payers, by the insurers? Maybe you saw some great examples, how it helped improve financial results. So it attracted more clients, maybe?
Ask the people who got sued.
That's great, yeah. So any other examples, any other real-time stories or cases?
Unfortunately, insurance reimbursement is not linked, which it needs to, and I think ICHOM is doing a lot of work in that space and in actually getting into prompts and, getting reimbursement, because it's not just about the episode of care, it's about continuity of care. But the reality is at this point in time, insurance does not differentiate based on outcomes. So it's really for hospital system that have to report a lot of parameters to their government, to their local authorities, or it's really for those who want really in terms of reputation to be seen right up there, who actually invest in this. And when they do, there are many benefits that come their way. It's about staff motivation. It's about, getting a great degree of satisfaction, not just for the doctors or the nurses, but everyone, that, we provide the best care. And it's not just us, it's data that speaks for itself. It's the patients who speak for the care they receive. And of course, it does have financial benefits when you look at, sometimes the average length of stay, and I give you many examples of the average length of stay coming down. And of course, for every litigation, it's a huge saving, and litigation can can be very expensive. And we are seeing a global trend in increase in litigation. It's not just the United States, but it's a global trend.
Thanks a lot, Professor. Wonderful. Michael, you wanted to say something on this topic?
Yeah, I think there's a lot of great examples coming out of Australia recently, because there's a linkage between not only our private payer system in our private hospitals to now paying for quality, but particularly in our public sector. So across our public system, hospitals and other non-acute providers, they are given or they're paid by activity-based funding. So they're given a certain pool or basket of activity figures that they are allotted to based on funding for that particular year. And if they go over that amount, then they're obviously not funded for it, but they have a responsibility for the public system to take care of their community and the community needs. So there's a clear strong financial incentive to ensure that you stay within those bounds of activity and ensure that you're able to drive as much activity as possible for the community. So related to that, you obviously want to reduce unnecessary readmission, reduce rework, reduce adverse events, etc. There is many cases of this, but one case that I've heard recently, a hospital was working on, I think DVT that was occurring with patients that were in hospital for longer periods, that was then creating them to have longer lengths of stay, eating up more activity, which was low value care, which they could have been using to do more elective surgeries, more emergency cases, etc. So just by using that performance data that comes out with the activity-based funding system across Australia, what they were then able to do was to have an improvement project around what was causing this. Was it in certain age groups, with certain procedures, whatever it was. And their improvement project actually showed that I think they saved thousands of units of activity that they were allotted in a year, which when you equate it to our what we call in our hospital pricing authority across Australia, which sets our national efficient price, you multiply the national efficient price by the activity units that were saved, and it came out to multi-millions of dollars that hospital was saving, that they could have been using and then did use on other more high value procedures that their community needed, like electives, surgery, like emergency cases, etc. And then that also makes a case to our state and federal governments for additional funding, that they're becoming more efficient in the future as well. So I think our system is set up in a way that you can make an easier case for the link between using data improvements and then how that results in outcomes on the financial side.
Thanks a lot, Michael. So I wanted to say that we will be concluding in about 10 minutes. So we'll be able to take a couple more questions, maybe 3 questions. But I wanted to remind you that on Facebook, we have our community of practice where the purpose is actually knowledge sharing. And we always, after each webinar, post questions there with answers. So if you had a question and you didn't get an answer, you can look for it in our community of practice. So now going back to the outcome measurement, COVID specific outcomes, any resources that you can recommend. This is the new reality that we have come across recently. So how to measure COVID related outcomes, any trends, any advice, any tips related to this?
I'll mention that we have a COVID standard set, and this is available on our website. This was developed last year. It was an expedited process, given that COVID was ravaging the world, but very much the same methodology that I've outlined, international group of experts that were multidisciplinary, and we use a transparent and Delphi modified Delphi process for decision making. So the set is actually on the website. I'll add the link to that because I see somebody's just asked about diabetes. It's available, and if there's questions related to how to do it, we happy to send me an email and I can channel you to the team members who can help you with that.
Thanks a lot, Neo. Actually, yeah, you partially answered already my next question. My next question was, we get lots of requests today regarding the specific disease-specific indicators. So what resources you can recommend to refer our audience to so that they can find the best solutions for the disease-specific case? ICHOM website is one answer. So anywhere else they can look?
Yeah, it really depends on what specifically are they measuring. And then, there are enough publications from different societies on different entities. There are publications from expert groups. There are publications from hospitals. So if you search on PubMed, you will get the answers.
Okay, thanks a lot. So I think we pretty much covered all the areas that we wanted to discuss today, because I know that Professor Anupam will have to leave us soon. So I think it's time. Neo, you wanted to say something?
Can I just mention one? I saw a question that came up while I was speaking about patients. Just if I could squeeze in a response, because I thought it was a really good question. It was about, and it's related to what Michael has mentioned about data overload, information overload, data overload. It was a question about how you incentivize and engage patients in responding to questionnaires, right? So in contributing to the data collection. So it's relevant to patients in terms of collection of patient-reported outcomes. It's relevant to doctors and nurses and clinicians in collecting clinical information. And I think there are things that can ease that process and make people more invested. One is digitizing, right? So if you have digital instead of paper, in that way, the questions will be fewer, questions that are not relevant to me will be skipped, etc. But I think that what's really been key in my experience is feedback, right? So if somebody is answering a questionnaire about the quality of life at this moment, 3 months after mastectomy for breast cancer, what the patient would find of value and would appreciate getting feedback on immediately is, how am I doing right now compared to similar patients at a similar stage in my care? How am I doing compared to how I was 3 months ago, right? So given some, or if it's a cardiovascular related kind of question, how am I doing in terms of lifestyle risk and behavior compared to others? So I think it's really important to, as part of getting good quality and complete data, to demonstrate and feed back information to the people who are giving the data. And that's a way to make the data complete, improve the quality, and sustain the data collection.
Thank you very much, Neo. So I wanted to thank once again all our wonderful experts today for their presentations, for their input and their useful tips, advice that they provided for our audience. I also wanted to thank our audience for asking questions, for being active today, for staying with us longer than expected as usual, but that shows that this subject is of interest, that there is need for it, and we are super pleased to see that. I also wanted to remind you that in our community of practice, you can still find answers to the questions that were asked today, and to welcome the audience to join our community of practice. So thanks a lot. Hope to see you on our next webinar. We will continue to discuss the importance of data collection, and we will send you an invite and the topic in a separate letter. Thank you very much once again, and hope to see you soon.
Thank you so much. And thank you to the amazing organizing team. I would like to thank Jana, Natalia, Julia, Maria. You guys have been amazing. And of course, the questions have been exciting. So wonderful to be on board. Thank you so much.
Thanks a lot,
our webinars will not be the same without our experts. So we thank you very much. So when you're leaving the webinar, you will be offered to fill out a survey on exit. Please do that. And only those who had Maria Kuznetsova as their name should be leaving their email. Otherwise, we will send you the slides automatically because we already have your email. Those who appeared as Maria Kuznetsova, we do not have your email, but for others who appeared under their own name, we have your emails. So thank you very much, and we look forward to seeing you at the next webinar.
Thank you.